Eicosanoids are autocoids, that is the local hormone that are derived from essential lipids, especially the lipids which are 20 carbon atom lipids and have 3, 4 or 5 double bonds. So main lipid amongst these is arachidonic acid. Arachidonic acid is released when an enzyme phospholipase A2 acts on membrane lipids, and this arachidonic acid then different enzymes act on it and lead to the production of either prostanoids or leukotrienes. So these prostanoids include prostaglandins like D2, E2, F2, thromboxane A2 and prostacyclin, that is prostaglandin I2. Now in this you see that all of them are denoted by certain numbers, and this number 2 denotes the number of the double bonds which are present in the side chain. That is why it is written as 2. On the other hand, leukotrienes name is derived because these chemicals were first derived from leukocytes, and they have 3 double bonds. Triene is 3 double bonds, and both of them are derived from 20 carbon atom lipid arachidonic acid. So first we will talk about prostanoids. What are these prostanoids? Well, prostanoids are produced when the enzyme cyclooxygenase, in short it is denoted as COX, the cyclooxygenase enzyme acts on the lipid arachidonic acid, and this leads to production of unstable prostanoids, that is PGG2 and H2. Unstable means they are broken down very fast, basically by the action of certain enzymes which are tissue specific. That means different enzymes are present in different tissues. This PGG2 and H2 are produced in all cells, but then depending on what enzyme is present in the cell, different other prostanoids are produced, and these enzymes include the enzyme isomerase, which will lead to production of PGE2, D2 and F2 alpha. Then we have thromboxane synthase, which is present in platelets, and this will lead to production of thromboxane A2 and thromboxane B2. And then we have prostacyclin synthase, which is present in vascular endothelium, and this leads to production of prostaglandin I2. Moving on to the next products, that is the leukotrienes. These are produced when the enzyme lipooxygenase acts on the arachidonic acid, and mainly it is produced in 2 pathways. That is, either there is production of 12-HPET or 5-HPET. From 5-HPET, there is production of leukotriene A4 due to the action of 5-lipooxygenase, and this leukotriene A4 again leads to the production of either leukotriene B4 or leukotriene C4, which is further forming leukotriene D4 and E4. Now this leukotriene C4 and D4, these are known as slow reacting substances of anaphylaxis because of the delayed and sustained effect which occurs with these leukotrienes, and mainly they are important in the pathophysiology of asthma because they cause this delayed and sustained bronchoconstriction. Okay, so that is leukotriene C4 and D4. Leukotriene B4 on the other hand is a strong chemotactic for various WBCs. Now we will not talk much about this leukotrienes in this video, so here only I will tell little bit. First is that for the action of this lipooxygenase enzyme, there is another protein required which is known as FLAP protein, 5-lipooxygenase activating protein. So when it interacts with arachidonic acid, then only the products will be formed. Second, since these leukotrienes are involved in bronchoconstriction in asthma, you see that even though asthma is an allergic condition, for the treatment we don't use antihistaminics. In fact, we need to use some leukotriene receptor blockers. Okay, so these leukotriene B4, leukotriene C4 and D4 has certain receptors. So actually this LTC4 and D4 are also known as cystinyl leukotrienes. Okay, cystinyl leukotrienes, and the receptors which are there for them, these are cystinyl LT1 receptor and cysteine LT2 receptor, and this LT1 receptor is the high affinity receptor, and this can be blocked by cysteine LT1 receptor blockers, example being montelukast. Okay, so this is used in asthma. In detail we will talk about when we talk about respiratory drugs, right? So moving on to our fundamentals on prostanoids, what are the actions of the prostanoids, how do they act, and what are the analogues which are used in therapeutics. So these prostanoids, I told you that they are produced by the action of the cyclooxygenase enzyme on arachidonic acid. But this cyclooxygenase enzyme itself is of two types, that is cyclooxygenase 1 and cyclooxygenase 2. Now, before it was known that cyclooxygenase 1 is the constitutive enzyme, that means it is always active and it is important for housekeeping action. For example, it is produced in stomach and it is responsible for mucus and bicarbonate secretion. It is PGE2, okay, mucus and bicarbonate secretion, thus preventing the damage of the stomach mucosa by the acid. Then in the platelets, it is present and it leads to the production of thromboxane A2 in the platelets, which is responsible for platelet aggregation. Then in pulmonary vessels it is present, which is responsible for dilation of the pulmonary vessels, and also in fetus it is responsible for maintaining the patency of ductus arteriosus. Okay, ductus arteriosus is a vessel which connects the aorta with the pulmonary vessel. So when the blood moves into the pulmonary artery, instead of going into the lungs, it directly moves into the aorta. So in fetus, we don't want the blood to go into the lungs. Directly it should go into the aorta, into the systemic circulation. So it bypasses the lungs. So in fetus, this PGE2 maintains the patency of the ductus arteriosus. But now it is not only COX-1 which is considered as constitutive. Now we know that even COX-2, cyclooxygenase 2, also has certain constitutive action. Example, in juxtaglomerular cells in kidney, this PGE2 and PGI2 is produced due to the action of COX-2 enzyme, and this leads to renal vasodilation, thus leading to increase in renal blood flow, and hence because of increase in hydrostatic pressure there will be increase in GFR. Also, it inhibits the tubular reabsorption. So, on one hand, it increases the GFR, on the other hand, it inhibits the tubular reabsorption, thus it increases the diuresis. So, it increases salt and water loss. Okay, that is one thing. Then in endothelium, this COX-2 leads to production of PGI2, that is prostacyclin. So, we have seen that thromboxane A2 is produced in platelets by the action of COX-1, and this is promoting platelet aggregation. On the other hand, prostaglandin I2 is produced by vascular endothelium by the action of COX-2 enzyme, and it inhibits platelet aggregation. Okay, this is important to remember because when we will talk about COX inhibitors in the next video, then we will see that how different COX inhibitors affect this platelet aggregation and can have different side effects. Okay, so that is about the constitutive action. Then COX-2 enzyme is also inducible. In case of inflammation, the production or the action of COX-2 enzyme is increased, thus leading to increased production of prostaglandins. But now again we know that it is not only COX-2 that it is inducible. In some cells, COX-1 is also inducible and is responsible for some aspects of inflammation. Now moving to how these prostanoids act. So there are different receptors for the prostanoids. We have, based on the name of the prostanoids, we have the different receptors. So first we saw PGD2, E2, F2. So their receptors are known as DP, D for this and P for prostanoids. Okay, so we have DP1 and DP2. Then for E2 we have 4 different receptors. So we have EP1 to EP4, and then for prostaglandin F2 we have the FP receptor. Okay, then for thromboxane A2, this is T, we have TP receptor, and prostaglandin I2 we have IP receptor. So these prostanoid receptors are now further classified based on their action and based on the way they act. So we have 3 different categories: contractile, relaxant and inhibitory. Okay, so contractile is basically the thromboxane and PGF2. So you will see this thromboxane and PGF2, their actions are quite similar because they are acting through this contractile receptors. Okay, basically they are acting on the receptors and stimulating the contraction. Okay, so that is thromboxane A2 and prostaglandin F2 alpha. Then we have EP1 receptor as well in this category. Okay, so EP1 receptor as well in this category, and these receptors are of GQ type. See, all of the prostanoid receptors are G protein coupled receptor, but in G protein coupled receptor, we know from our physiology, G protein coupled receptor is of various type. There is GS, which acts by stimulating adenyl cyclase. There is GI, which acts by inhibiting adenyl cyclase, and then we have GQ. GQ is by stimulating the phospholipase C. So this contractile category of receptor, it acts by GQ type of G protein coupled receptor, which stimulates phospholipase C, leads to production of IP3 inositol triphosphate and DAG from phosphatidyl inositol diphosphate. So this phospholipase C acts here, leads to production of IP3 and DAG, and this IP3 causes release of calcium from the endoplasmic reticulum. So this basically increases calcium, and simple to remember, increased calcium, that means it will cause contraction. So these receptors are in contractile category. Then moving on to relaxant category, that is the GS type of G protein coupled receptor, and it acts by stimulating the enzyme adenyl cyclase and thus increasing the production of CAMP. So in this we have PGD2, then we have PGI2 and the even number PGE2 receptors, that is EP2 and EP4. EP2 and EP4, they are of the relaxant category. Then last one is inhibitory, that is EP3. It acts by decreasing the adenyl cyclase because this is of the GI category, which inhibits the adenyl cyclase activity, and this causes decrease in CAMP. Okay, so these are the three main types of prostanoid receptor. Now concept you remember here that prostaglandin F2 alpha and thromboxane A2, they will have similar action because they are acting via these receptors. On the other hand, prostaglandin I2 will be mainly vasodilation, okay, because that is relaxant. But prostaglandin E2, because some of its receptors are contractile and some of the receptor are relaxant, its action will vary depending on which receptors are stimulated and also depending on the concentration of this prostaglandin E2. Okay, so with this concept, let us move forward. So first, it's action of smooth muscle. Which smooth muscles are we talking about? We are talking about bronchus, gastrointestinal smooth muscle and uterus. Okay, so in bronchus, which will cause contraction? Yes, prostaglandin F2 alpha and thromboxane A2. I told you the receptors, right? Then relaxation will be caused by PGE2 and PGI2. Similarly, in gastrointestinal smooth muscle, we have PGF2 alpha and thromboxane A2, which cause contraction. And in GI smooth muscle, we have two smooth muscle, longitudinal smooth muscle, okay, that is basic anatomy, longitudinal smooth muscle and circular smooth muscle. Okay, circular smooth muscle, we see it is very prominent in sphincters. Longitudinal smooth muscle, it is like this. Okay, longitudinal smooth muscle, it is like this, and circular smooth muscle, if it contracts, it will just decrease the diameter. So this prostaglandin F2 alpha and prostaglandin A2 basically cause contraction of both, and that is why they are known as spasmogenic. Spasmogenic. On the other hand, prostaglandin E2 actually contracts longitudinal muscle but relaxes circular muscle. So I told you the action of the PGE2 will vary. So it contracts longitudinal muscle but relaxes circular muscle. So when relaxation of the circular muscle will happen, that means sphincter is going to open, and contraction of the longitudinal muscle, that means this will shorten like this. It will push whatever is the food material there, it will push forward. Basically, it is going to increase peristalsis, right? Then in uterus, prostaglandin E2 is essential for onset of parturition. In fact, it is the one which initiates contraction. It is also responsible for softening of the cervix during parturition. Okay, and prostaglandin E2 is also implicated in dysmenorrhea, that means pain during menstruation. And we will see when we will talk about COX inhibitors that decrease in production of these prostaglandins relieves pain of dysmenorrhea, right? So in this video, we are talking about the analogues of prostaglandin. So remember, when we talk about the analogues, we will discuss that what are the analogues which act on these effects, that is promoting the parturition, right? Then we have some other smooth muscles as well, that is the smooth muscles of blood vessels. So based on this, we have the cardiovascular action of the prostanoids, basically based on the action on the smooth muscles of the blood vessels. Okay, so again, prostaglandin F2 alpha and thromboxane A2, whether they will be vasoconstrictors or vasodilators? Yes, they will vasoconstrict, and basic action is on pulmonary arteries and veins. Okay, remember, these are prostanoids are local hormones, so wherever they are synthesized, so they act in a paracrine manner on the cells which are located there itself. Okay, so prostaglandin F2 alpha and thromboxane A2 are the vasoconstrictors. Then prostaglandin E2, depending on which receptors it is acting, it will have different action. If it acts on EP1 and EP3, there will be vasoconstriction. Yes, we saw that EP3 basically is inhibitory type, but here we see when they are stimulated, it causes vasoconstriction. And EP2 and EP4, we saw that it is in the relaxant category. So PGE2 is important for vasodilation and also for maintaining the patency of ductus arteriosus. This we have discussed before also, right? So yes, ductus arteriosus is the vessel which connects this pulmonary artery with that of the aorta, so that the blood is bypassed directly into the aorta. It doesn't go into the lungs. Very important in fetal stage, right? Then we have PGI2. PGI2 again is the relaxant category, so it causes pulmonary vasodilation. And when we talk about the analogues which are acting, we will see that there are certain drugs which can be used because of this action on pulmonary vasodilation. Moving on to next action, that is action on the platelets, very important. So thromboxane A2, which is produced by the action of COX-1 on arachidonic acid in platelets, it promotes platelet aggregation. On the other hand, PGI2, it is produced by the action of COX-2 in vascular endothelium, and it inhibits platelet aggregation. Okay, this is very important because I'll tell here only little bit that there are certain COX inhibitors, the enzymes, these are known as NSAIDs, non-steroidal anti-inflammatory drugs. If we inhibit both these enzymes, then the major action is on thromboxane A2 because platelets do not have nucleus. Okay, so once this enzyme is inhibited, it is inhibited permanently for that particular platelets. New platelets need to be synthesized for this enzyme to be present. Okay, so COX-1 is inhibited and hence there will be decrease in platelet aggregation. But yes, COX-2 is also inhibited, but that is not permanent. Okay, because vascular endothelium has nucleus, it can synthesize enzyme as well, and hence it can synthesize prostaglandin I2 as well. So this effect doesn't occur much because of the non-selective COX inhibitors. That means COX inhibitors which are inhibiting both the enzyme. Main effect is on decrease in the platelet aggregation. So this can lead to bleeding tendencies. Okay, bleeding tendency. On the other hand, if we use drugs which selectively inhibit COX-2, then platelet aggregation is going to be not countered by this PGI2 because mainly PGI2 is inhibited, and hence there will be increase in platelet aggregation by COX-2 inhibitors. So the side effects of COX-2 inhibitors include risk of myocardial infarction, stroke because of increased tendency of platelet aggregation. Okay, very important. We will discuss again when we talk about COX inhibitors or NSAIDs. Okay. Moving on to other actions of prostanoids, we have gastrointestinal secretion action. So this PGE2 and PGF2 alpha actually increase the intestinal secretions, and that is why when these drugs are given, one important side effect of these drugs is watery diarrhea. Okay, because they increase the secretions. In the stomach, This PGE2 is responsible for mucus bicarbonate layer, which prevents the gastric mucosa from acid. I have told before as well that COX-1 enzyme is required for that. Then in kidney, again we have discussed before when I was talking about COX-1 and COX-2 that COX-2 enzyme leads to production of PGE2 and I2, and they increase the renal blood flow because of renal vasodilation. This causes increase in GFR because of increase in the hydrostatic pressure in the glomerular capillaries, and they also inhibit the tubular reabsorption, thus causing the diuresis, that means increased salt and water loss. Increased salt and water loss in urine. Then there are certain CNS effects. One, it is responsible for fever. Okay, how? In case there is increase in the production of interleukins, this acts on vascular endothelium of the hypothalamic area. Okay, in the preoptic hypothalamic area, the vessels which are there, these interleukins act on that and increase the action of COX-2. So this is inducible. Okay, so increased action of COX-2 leads to increased production of prostaglandin E2. This crosses the blood-brain barrier and acts on the hypothalamic neurons. So thermosensitive neurons in hypothalamus are there, it acts on them. This causes increase in temperature, right? So this is responsible for fever. Why we are talking about this? Simple, that if we give COX inhibitors, then that will also act as antipyretic. So that again we will study in the video on COX inhibitors, right? Then there is another action in pain where PGE2 and PGI2 sensitize the pain receptors to various mediators. Okay, so these prostaglandin E2 and I2 are produced from damaged cells. Okay, damaged cells, and they act on the sensory nerve endings. So if this is the tissue, here the nerve endings are there, which will carry the pain sensation to the spinal cord and from there to the brain. Understanding? So this is the damaged cell, and here prostaglandins are released and they act on these nerve endings. So they are sensitizing the nerve endings. In fact, they are responsible for hyperalgesia. Hyperalgesia. Okay, so very small stimulus will also cause very high pain in the area of the tissue which has been damaged. Okay, so that is hyperalgesia. Again, if we give COX inhibitors, what will happen? There will be decreased production of the prostaglandins, and obviously that is going to decrease pain, right? So it is very important to understand the action of prostanoids, because when we will talk about the COX inhibitors, you will be able to correlate this, right? Now moving on to the therapeutics of these prostaglandin analogues, right? So first is PGE2 analog. PGE2 analog, that is the dinoproston. Dinoproston is PGE2 analog, and it is used for facilitating labor, that is cervical ripening, and also for inducing labor. Okay, so that we have seen in the actions of the prostanoids. Here we saw that prostaglandin E2 is essential for onset of contraction, and it also causes softening of surface. So that's what we are talking here, that dinoproston, a PGE2 analog, is used for facilitating labor and also induction of the labor. Then also it is used for abortion up to 7 weeks. Okay, so for the termination of pregnancy up to 7 weeks, this prostaglandin E1 analog, prostaglandin E1 analog can be used. Yes, till now we have not talked about PGE1 analog, but it is a more stable synthetic analog, and this is misoprostol. Misoprostol. So it is used along with mifepristone, that is an antiprogestin. See, progesterone maintains the pregnancy. So if we give antiprogestin, that is the mifepristone, first mifepristone is given, and following that misoprostol is given, which is PGE1 analog. It is used for termination of pregnancy, which is up to 7 weeks. Then apart from that, another prostaglandin analog, that is PGF2 alpha analog. It is used for mid-term abortion. Mid-term abortion, that means in second trimester. So this PGF2 alpha analog, if given in second trimester by intraamniotic injection, then it can induce the termination of the pregnancy in second trimester, and that analog is carboprost. Okay, dinoproston, PGE2 analog, PGF2 alpha analog, carboprost. Then this carboprost is also used in postpartum hemorrhage. The drug of choice for postpartum hemorrhage treatment as well as in prophylaxis is oxytocin, but prostaglandin F2 alpha can also be used, that is the carboprost can also be used for postpartum hemorrhage. Then we have another drug, that is prostaglandin E1 analog. Again, E1 we have not discussed, but for therapeutic purpose, prostaglandin E1 analog is used. One, the use is maintenance of patent ductus arteriosus. So, in certain conditions in fetus where certain congenital heart diseases are there, till the corrective surgery is done, we need to maintain patent ductus arteriosus. Okay, just after the birth, actually ductus arteriosus should close, but in certain heart conditions, it is important that this patency of ductus arteriosus is maintained. Okay, so for that PGE1 analogues are used. Analog name is alprostadil. Okay, second is prevention of NSAID induced gastric ulcer. Actually, these NSAIDs are the COX inhibitors. Okay, now I have told you before that COX1 enzyme is important for the production of prostaglandin E2, which is important for production of mucous bicarbonate layer, preventing the gastric mucosa from damage from acid. Right? Now, if we use NSAIDs chronically, this COX1 will be blocked and hence there will be decrease in production of this protective prostaglandin E2. So, this mucous bicarbonate layer will decrease and hence the stomach will become prone to damage. In fact, chronic use of NSAIDs will lead to gastric ulcers. Okay. So, to prevent that, we can use these analogues, PGE1 analogues, that is the misoprostol. So, for maintenance of PDA, alprostadil is used. Again, PGE1 analog for prevention of NSAID-induced gastric ulcer. Misoprostol is the drug. Okay, but remember the drug of choice is proton pump inhibitors, not misoprostol. Drug of choice, first drug of choice is proton pump inhibitors. But yes, PGE1 analog can also be used. It is very specific drug because it is acting on the pathophysiology where the damage is occurring. Right? Then PGE1 analog alprostadil can also be used for impotence. And again, it is a second line drug, not the first line drug. In this, alprostadil is directly injected into penis and this can help in impotence because it will cause a vasodilation. Right? Then next use is the PGI2 analog for pulmonary hypertension. See, we have seen before that this PGI2 was causing pulmonary vasodilation. It is acting through inhibitory receptor and it is causing pulmonary vasodilation. So, in case of pulmonary hypertension, if we cause pulmonary vasodilation, it will relieve the hypertension. Okay. So, this prostaglandin I2 analog can be used for pulmonary hypertension and the drugs used are epoprostenol or iloprost. Iloprost can be inhaled. Okay. It can be inhaled. So, the I for I. Then finally we have prostaglandin F2 alpha analog, which we have discussed in glaucoma as well. It is the first line drug for the treatment of open angle glaucoma. It increases the uveoscleral outflow. So you can watch my video on glaucoma and see that how this is acting. Right? So in summary, what analogs we have seen? We have seen PGE2 analog, that is the dinoproston, which is used to facilitate labor by cervical ripening. It is given intravaginally. So it is kept in the vagina and it facilitates labor by causing cervical ripening, or it can also be used to induce labor. Then we have PGF2 alpha analogs, which can be used for termination of the pregnancy, both PGE1 analog also and PGF2 alpha analog also. PGE1 analog is used up to 7 weeks along with mifepristone. PGF2 alpha analog is given by intraamniotic injection, that is carboprost is given by intraamniotic injection. Then for postpartum hemorrhage, we have PGF2 alpha analog, that is carboprost, right? Then PGE1 analog, we have misoprostol for prevention of NSAID-induced gastric ulcer, alprostadil for maintenance of patency of ductus arteriosus and also for impotence. Then prostaglandin I2 analog, that is epoprostenol or iloprost for pulmonary hypertension. And then again we have prostaglandin F2 alpha analog, which is the first line drug for treatment of open angle glaucoma. Also, one thing I missed, this prostaglandin I2 analog can also be used as a anti-aggregatory, platelet anti-aggregatory drug. We have seen that it is an inhibitor of platelet aggregation. So it is used as platelet anti-aggregatory drug during dialysis and cardiopulmonary bypass. Okay, dialysis and cardiopulmonary bypass, and can also be used for storage of platelets for transfusion, right? So that is also PGI2 analog, that is epoprostenol. Okay, so that was about the action of the prostanoids, leukodrins, and about the prostaglandin analogues. And as always, the video notes of this lecture will be available for free download from the app. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.